Hello, this is Jeff Lighthall from the Department of Anesthesia. This is a module on the pathophysiology of shock states. Your current understanding of shock states might be a diagram such as this that describes different kinds of syndromes, depending on whether the problem is with the heart or within the vasculature and its ability to maintain blood pressure, or whether it's a problem with volume, be it just clear fluid losses or hemorrhage. Unfortunately, patients don't show up on the wards and in other places with these labels and these parameters fully characterized. And so while somebody with a PA catheter can display very low cardiac output and high vascular resistance, you're not going to see that on somebody who just has some kind of undifferentiated problem on the ward. So what does describe a patient's development of a shock state? It's either one or two of these different relationships. The first is the relationship between the patient's blood pressure and the normal range of blood pressures that that patient's experienced up to that point in their life, the so-called autoregulatory range. If the blood pressure is not in that range, then the organs are not getting sufficient blood flow to meet their demands, and this is sufficient to have that organ become at risk for dysfunction. The other relationship that, if abnormal, can lead to organ dysfunction and development of a shock state is a supply of oxygen that does not meet the demand. So the supply of oxygen is often called delivery, or DO2, and demand is V.O2. So often we talk about this being the autoregulatory relationship, and often we talk about this being the V.O2 DO2 relationship. So let's take a look at what those look like. The relationship between blood pressure and organ blood flow, the so-called autoregulatory curve, should be pretty familiar from physiology. And the curve has the following shape, and this is mean arterial pressure on the x-axis. And keep in mind that's the product of cardiac output and vascular resistance. And on the y-axis is organ blood flow. And so we know that if the blood pressure is below a value, usually a mean of 60, it can be lower in other cultures besides ours that eat less salt. But anyway, if you have a blood pressure that's less than 60, your organ blood flow is going to be linearly related to that blood pressure. And that describes a situation where you might not necessarily get the kind of blood pressure that that organ is used to. Above that lower inflection point, the body is able to maintain a very constant blood pressure up to means of 130 to 160, very constant blood flow within those organs. And then if blood pressure is higher, it's pretty hard to maintain decent blood pressure there. You get vasogenic edema, you can get hyperemia, and you can get some flow alterations. But the body works incredibly hard at keeping your blood pressure within this range via a number of direct vasoconstrictors and other neurohumoral mechanisms. And when it gets below this value here, you're at risk for developing organ dysfunction, and this would define you as having a shock state. Keep in mind, though, is there's some patients with chronic hypertension and other atherosclerotic disease, etc., whose curve is right shifted, and so that mean of 60 that might be just making it for this patient might be completely underserving this patient here, who might actually auto-regulate at a pressure starting at, say, a mean of 70. So let's take a more detailed look at the relationship between supply and demand for oxygen. We'll develop a curve here in which V.O2, or oxygen demand, which should be the same as consumption, is on the y-axis, and Auxin Delivery, DO2, is on the x-axis. So before we plot out this relationship, let's just talk about what determines each of these. So what your demand is going to be based on a number of factors. One is just, behavior and activity, muscle mass, kind of related to behavior and activity is metabolism. So some of it might be because you have a high muscle mass and you're exerting tons of energy going up a flight of stairs. But in hospitalized patients, this can be related to things like temperature, thyroid status, and some weird metabolic syndromes like malignant hyperthermia. And it can also be modified by things like cooling, paralysis. So in a lot of patients, a lot of this is who are just kind of like hanging out on a ventilator or in their bed. A lot of this is just really related to what's the temperature. So that can be anything depending on the patient's state of body as described by those factors. And the units here are either mils of oxygen per minute, or in super athletes, liters, whatever kind of range you're dealing with can be plotted on there. Auxin Delivery, in contrast, is based on cardiac output times the content of arterial oxygen, which can be both bound or dissolved. Dissolved is very minimal. This is the 0.0031 times your PaO2 from your blood gas. And bound is the 1.34 times your oxyhemoglobin saturation times your hemoglobin content. And this can be, this is your big contributor. And so if you kind of look at it as far as major factors, if you consider this pretty negligible and you consider this a constant, and if your saturations are near 1.0, essentially DO2 is cardiac output times hemoglobin. And again, the units of DO2 are going to be the same as for V.O2. And so you can imagine that at very low levels of oxygen delivery, actually let's start over. Let's just say that this is what your body is demanding. This is 1 liter of oxygen, and here's 1 liter of oxygen out here. And so if your body is demanding 1 liter and you're able to deliver 1 liter of oxygen, that point is developed. Or if you're delivering more oxygen than what's being demanded, this whole series of points here describes your V.O2 DO2 relationship. However, when your DO2 becomes dangerously low and you start dipping into levels that are lower than what your body is demanding, this is what the curve looks like. And let's say your body is demanding 1 liter here, but you're getting only 250 mils here, then what develops here is an oxygen debt. And this is going to have a huge impact on cell function. It's going to mean that you only get 4 moles of ATP per glucose mole rather than 36. It means you're not going to be pumping sodium out of your cells. It means you're not going to be doing all the specialized things that the cells are doing, maintaining key concentration gradients, housekeeping functions, repairing itself, and it becomes a huge setup for cell necrosis. So in thinking about shock states, things that will lower your cardiac output or your hemoglobin, or actually both in the case of hemorrhagic shock, those will land you down on this part of that curve. And that is really what's at play when your hemorrhage or your whatever kind of cardiac disease you have becomes a shock state. It's defined as those conditions that diminish your delivery of oxygen such that you start occupying this very critical part of that curve. Just to give you an idea where normal people live, normally we're living way out here, and you're sitting down reading a book, big earthquake comes along, you get really scared, your oxygen demand and metabolism is going to get revved up, and so is your heart and your venous return. And so, your curve is going to look something like this. You're going to crank your V.O2 incredibly high, but at the same time, your cardiac output is going to be moving out here too, and you're still going to be functioning at a part of the curve where your oxygen delivery exceeds what you're actually demanding. Exceptions to this are things like Olympic 50-meter sprint races, where you just take one deep breath, put your head down, and just plow to the end of the pool. And yeah, you've got tons of lactic acid and buildup of anaerobic metabolites by the time you get to the end of the pool, but your body takes care of that very quickly. Sustained residence on this part of the curve, whichever one you may be living on, is going to give you is going to define you as having a shock state. So, as what was mentioned just a few seconds ago, problems with cardiac output or red cell mass are going to give you shock states based on development of V.O2, DO2 imbalances. And that's generally where they will land you. Interestingly enough, when your cardiac output is down and your volume status is low and you're bleeding, your body does a really good job at trying to maintain blood pressure. And in fact, you might vasoconstrict like crazy, and you might end up having pretty life-threatening hemorrhage with a decrease in cardiac output because your preload is down, plus your red cell mass is down. But you might be right here on this edge with a blood pressure that looks pretty acceptable. And certainly you see this in trauma victims. Their blood pressures are normal, but their heart rates are sky high. They're horribly vasoconstricted. And when you look at blood chemistry, they're an anaerobic nightmare. Their pHs are 7.1 and they have lactate levels of 14, 15. So in dire need of resuscitation is defined by impending cell injury based on this kind of problem right there. Where the distributive shock patients land is over here on this curve where, again, MAP is cardiac output times SVR, and patients with inflammatory conditions, infections, neurologic injuries, things that prevent their vessels from constricting, no matter how good your cardiac output is, if you can't maintain vascular tone, you're going to slip down to this part of the curve. And so typically the distributive shock patients are those that are down here with the blood pressure that's unacceptably low for their organ function. And even when you resuscitate them and try to bring their cardiac output up without the ability to maintain reasonable vascular tone, you're still going to be hypotensive. And so typically that's where you end up with distributive shock. Now, none of these are pure syndromes. You can have distributive shock in a patient who has some structural heart disease, whether it's a valvulopathy or infiltrative myocarditis. And so no matter what you do resuscitation-wise, you're not going to increase their cardiac output very much at all. So you might have, in some of these cases, kind of relative cardiac failure along with whatever is creating the distributive picture. So again, these are pretty prototypic syndromes, but there is certainly a lot of overlap and possibility for having abnormalities in a couple different categories. For example, you can be borderline anemic and then develop an infection and really have a problem that's defined by low blood pressure, but at the same time you might have some problems with Auxin delivery. So in a nutshell, this is the explanation of different kind of conditions and that lead to shock states and what to look for. And where this is useful is in taking a look at, say, a patient that you get called for because their mental status is abnormal. So this could be a primary neurologic event, or this could be something that's related just to whole body circulatory disruption. And this gives you some tools that you can use to evaluate those relationships there. So before I finish, I guess it's important to think about how do you evaluate these physiologic relationships. So So the organ blood flow, blood pressure relationship. It's really important to know what the patient's true baseline, which is outpatient blood pressure is. A mistake that's often made is someone will look at a blood pressure that comes in that's recorded in the ER, say when somebody comes in, and they'll say, oh, that's his baseline. And so then when the patient has mental status changes and it's seen that the blood pressure is pretty darn close to where they were in the ER, the assumption is made that, oh, hey, well, this patient has an okay blood pressure. Well, no, that's not true. This is their blood pressure when someone decided they were sick enough to take him into the ER, probably not their true baseline. So you have to compare their current blood pressure to their true baseline. And so you have to actually look at outpatient records to see this. And the nice thing about integrated healthcare systems like Stanford Healthcare, VA, and Kaiser is if you get your outpatient care at the same place you're getting your inpatient care, you can go back and look at what was the patient's pre-op blood pressure. What were they doing when they came to their clinic for their checkup last year when everything was basically okay, or maybe just one little medicine or problem was being adjusted here or there. A great tool, at least at the VA, is found from going to the patient's cover sheet. And so when you open up a patient's chart, you'll get this cover sheet that looks like this. And then down in the tile that's pretty much right in that location, you'll see vital signs. And if you double click the blood pressure, another screen will open up that looks like this. And that is time on the x-axis. Let's just say this patient's been in the VA system since 2008. And it'll show what systolics and diastolic blood pressures have been generated over that time. And there'll be tick marks for systolic and diastolic. The other thing you'll see is just like some clusters in here that are kind of interfere with things. And these are typically admissions where they're getting vital signs 3 times a day instead of every 3 to 6 months. And so best thing to do, ignore these guys because this is when some other kind of pathology is going on. And then just take a piece of paper, note card or something, and just basically kind of figure out what the median is for both of these. And by just drawing a straight line through all the values, you can use a scale to arrive at what you think their normal blood pressure mode is. And then over here on this screen, you can click different date ranges like all values, last month, last week, etc. And so that what you click there kind of defines what you look at here. But anyway, this is a great tool and something I would encourage you to use if you're at the VA. If you're not at the VA, good indication of what the patient's blood pressure is can come from, one, just asking the patient, and if they're on a huge slew of blood pressure lowering medicines and their blood pressure is, something like this, you could pretty confidently assume that they're hypertensive and probably autoregulated range that's way, way higher than what you're looking at. So how do you evaluate V.O2, DO2 in that relationship? So a few hints have been given to what one can use. So given that the abnormal part of this curve down here is where supply is not meeting demand, what's going to happen is anaerobic metabolism will take over. And so things like anion gaps that are wide, pHs that have dropped to dangerously low levels, lactate levels that are on the rise or abnormal, all those are stigmata of anaerobic metabolism and can give you an indication, although indirect, that you're living down here in this part of this curve. And the more the merrier. So again, a high lactate can mean a number of different things, but in the context of someone who seems like there's some organs at risk. They seem like they're vasoconstricted, their heart isn't working, there's some other disease process going on. When you start racking up a number of these abnormalities, it's a pretty clear sign that you are down in that part of the curve. Another thing that you can do is look at mixed venous O2 sat. And if you see changes in mixed venous O2 sat that are not accompanied by huge changes in patient activity, meaning V.O2 is pretty constant, more or less. And so if you see some big changes in mixed venous O2 saturation, that's an indication that you're basically on a given V.O2 curve, that you're moving in this direction from the healthy side to the unhealthy side. And that can mean that you've got a problem with the changes, either your hemoglobin or your cardiac output. Mixed venous O2 sat obviously involves this hemoglobin, cardiac output, or V.O2. So the more of these factors that you can hold constant, the stronger your inference is that it could be for the final factor that is not constant. And so again, like, there's not any mixed venous O2 sat that's diagnostic for shock per se, but if you have values, like normal is 70%. So if you have values that are down in the 50s or the 40s or the 30s, it means that you're really over extracting oxygen, probably because your delivery is not very good at all. And so that is yet another piece of data that you can use to triangulate in on this whole situation to define an abnormality. Nicely, sometimes patients on the floor have PICC lines, and as you recall, the tip of PICC line is in one of the central veins, and so you can obtain a central vein saturation from a sample of blood from a PICC line and come up with a value that's pretty meaningful, depending on the situation. Okay, so that is it. The main thing is you're never going to get called for somebody who has one of the prototypic shock classifications. You're never going to get a call saying this guy's got high cardiac output and low SVR. Can you please evaluate? It's always going to be something non-specific. And so you need to have some tools to take a look at the patient and evaluate him. And those tools are basically, first off, understanding what the relationship between their blood pressure is to normally where they live, and also the relationship between supply and demand for oxygen.